thank you everyone for joining us tonight for our latest webinar. I think this is our 15th webinar, which is really good after 2 years of a year and a half of going. As usual, the webinar will be recorded and it will be available on our YouTube channel, the Sussex Eye Group, and I will upload that probably next week. The webinar will run for about an hour and there'll be time for questions at the end. So if you have any questions, please, at the bottom of your screen is a Q&A box. If you type in there, and at the end of the webinar, I will then pose the questions to our speaker. There is one CPD point available tonight for optometrists, dispensing opticians and contact lens opticians. And as it's changed from CET to CPD, I will send you a certificate of that you've attended the course if you have registered and logged on for the full duration of the webinar. And I will aim to do that this weekend, but as you can understand, it takes a bit of time to do. So, but you should get your certificate. It's GOC says you have 10 days to send the certificates out, but I'll try and do them this weekend.
Do I get one?
If you would like a certificate, I will send you one as well.
Okay.
So I would like to welcome our guest speaker tonight, Mr. Ioannidis. After finishing his medical school training in Italy, he then went on to complete his ophthalmic surgical training in Athens, working at the University Pediatric Hospital and the prestigious Red Cross Hospital of Athens. He then moved to Wales to join the ophthalmology department at the Singleton Hospital in Swansea in 2011 and was there for 2 years before he became part of the ophthalmology team in East Sussex. In order to expand his anterior segment experience, he then completed 2 years of an honorary clinical attachment at the corneal plastic unit at the Queen Victoria Hospital in East Grinstead, alongside his job at East Sussex. Currently, he is a consultant surgeon with a special interest in anterior segment conditions and medical retina, as well as being the ophthalmology clinical governance lead at East Sussex Healthcare NHS Trust. So thank you very much for tonight, Mr. Ioannidis. I'd like to hand over to you now.
Thank you, Ian, for the introduction, a very generous one as well. So I'm going to start sharing my screen. Let's see here. Great. Give me a few seconds. So great. So thank you everybody for attending this webinar today, this Thursday evening. I hope I will make it a little bit interesting. We're going to talk about the Pentacam in our clinical everyday practice. If some of you might remember, topography is an art. It all started with a Placido disc, trying to figure out if the surface of the cornea was regular or irregular. Then eventually we tried to measure this surface, this interesting surface, this transparent window, as I call it, to my patients, so they understand better. With this is the Javal. This is something that we were using in to measure the case of the cornea. Then eventually we moved to anterior segment topography, like the Medmont, or eventually we started with tomography with the orb scan from Bunsen Loeb. And eventually now we moved on to the Pentacam, which is still considered the golden standard for corneal tomography. And then there are various versions like the Galilei or more advanced versions that consider use also OCT technology, like the Corvis ST. I'm not going to go to much theoretical stuff because I think everybody can check these. And I'm going to concentrate more on some more practical stuff for your everyday practice. Now, let's start with a couple of words, but that sometimes can sound a little bit difficult to understand. I'm Greek. For me, it's Greek to me, so it's easy for me. There's this. You have to distinguish between topography and tomography. Topography is the study of the shape of the corneal surface, so the anterior surface, while the tomography allows a three-dimensional section of the cornea to be presented. So we call it corneal topography or Pentacam topography, but it's actually a tomography, if we want to be precise on our terms. A little bit of the theoretical stuff, I'm not going to stick too much on that, but the Pentacam, which I'm going to talk about, it's the one that I'm familiar with, even though I discussed there are other imaging technologies. The Pentacam is a rotating same-film camera system for anterior segment analysis. It measures the topography and elevation of the anterior and posterior corneal surface and the corneal thickness. The advantages of the same film camera include higher depth of focus and sharper picture. So the machine consists of a rotational device which measures the procedure. The motion procedure generates same film images in 3 dimensions with a dot matrix fine mesh in the center due to the rotation. It takes a maximum of 2 seconds to generate a complete image of the anterior eye segment. It takes from 25 to 50 photographs, and any eye movement is detected by a second camera and corrected for the process to some extent. Now, the first map that we encounter when we do a corneal tomography is this one, the 4-map refractive. So I'm going to try to break that down to make the interpretation easier for you or for everybody who encounters and sees a Pentacam. So it consists of 2 parts. We have a part on the left which consists of the corneal parameters, and then the 4-view refractive composite map on the right side. Now I'm going to go through the corneal parameters one by one, so you are start to familiarize a little bit with the picture that you see when you see a 4-map refractive. First of all, we start with the quality, the QS. In this part, we see the quality specification. It specifies the quality of the topographic capture and should be displayed OK. So that's easy to miss sometimes. So just if you are taking a tomography map, make sure that this parameter is OK because it will show you that you have a reliable image. Then we have the Q value. The value of Q within the central 8 millimeters, which represents the asphericity of the anterior surface of the cornea. The normal value is -1 to 0. Plus Q is found in more than 3 diopters of myopic ablation and RK, and over minus is found on more than +3 hyperopic ablation or KC. So by only looking at these 2 parameters, you have the first idea of what you are about to encounter or interpret in your next step. Then we got corneal parameters. I'm sure that everybody's familiar with K1 and K2. The K1, the flat case, is the curvature power of the flat meridian of the anterior surface of the cornea, measured within the 3 millimeter central zone and expressed in diopters. Normal K1 is more than 34 diopters, and it should be considered in myopic correction. An example of how we interpret this for your everyday practice on when you see a map, especially if a patient had previous refractive procedure, it's that each -1 diopter correction reduces the flat case by around 0.75. So the final flat case should be more than 34 diopters. Otherwise, positive spherical aberrations might be induced. For example, if we have a patient with a K1 41 and we consider a -8, very generous ablation, the final K would be 35. Then we got the K2s, the steep meridian, the curvature power of the steep meridian of the anterior surface of the cornea, measured again within the 3 millimeter central zone and expressed in diopters. The normal K2s is less than 49 diopters. This should be considering any hyperopic ablation, that each +1 correction will add 1.2 diopters to the steep case. And for example, if we have a patient with 45 diopters, we're doing a +6 ablation, then the final case would be around 52.2. We continue to see the corneal parameters. There's another value that is very popular, the Kmax. This is the mean curvature power of the anterior surface of the cornea within the 3 millimeters of the central zone and expressed in diopters. Should be considered to avoid any flap complications, whoever does this procedure. Just an idea, when the Kmax is less than 40 diopters, you might encounter a free flap complication because it's very flat. And while a Kmax more than 46 diopters may result in a buttonhole complication. The Kmax as a value, the normal is less than 49 diopters. The normal difference in Kmax between the 2 eyes is around less than 2 diopters, and the normal Kmax minus the K2 difference in the same eye is less than 1 diopter. Whenever the difference is more than 1, Kmax should be considered instead of K2 in the calculations for hyperopic corrections to avoid post-operative irregularities. I know it might sound a little bit technical, but sometimes when you see these values and you are familiarized more with these values, you start to consider that when you see a number on your Pentacam. Now I'm going to go to something that everybody's more familiar, the astigmatism, that shows the amount of corneal topographic astigmatism on the anterior surface, which should be compared with a manifest refraction on the astigmatism, then the axis, and again compared with the manifest refraction, and then we've got the pachy-apex, which represents the thickness at the apex of the cornea. The computer considers the apex as the origin of the coordinates, where x and y are horizontal and vertical meridians. 0 is displayed in both squares of pachy-apex coordinates. Other parameters that we consider in the left part of our corneal topography is the pupil center, which corresponds to the pupil center location, its coordinates, and pupil diameter right down, and this part here of the Pentacam, which is the diameter in the pupil in circumstances of the capture, like photopic, scotopic, or mesopic. Usually we prefer to do the Pentacam, we do the Pentacam in a very dark room, just for every patient, just to have the best possible image. And then we got the thinnest location, which represents the thickness and location of the thinnest point of the cornea. The definition of the thin cornea below 470 microns with normal topography, and cornea below 500 microns with abnormal topography. The normal difference in thickness in the thinnest location between two eyes is less than 30 microns. And finally, on our left part of our topography, we have the corneal parameters. We have the anterior chamber volume, the anterior, the ankle, the ankle angle, and the anterior chamber depth. The anterior chamber with volume less than 100, and anterior chamber angle less than 24 degrees, and anterior chamber depth less than 2.1 millimeters may have the risk to develop angular closure glaucoma. So you see that gives you a straight image if the patient has like a narrow angle eventually and shallow AC. And generally some parameters to use phakic IOLs are that the anterior chamber depth can be more than 3 millimeters, anterior chamber angle more than 30, and the anterior chamber volume more than 100. Now, I'm going to discuss about the other part of the Pentacam, which most people might be interested. It's the four most important topographic maps, are the anterior curvature sagittal map, the anterior and posterior elevation map, and the pachymetry map. In each one, both shape and parameters should be studied. So we got the anterior sagittal map, and the steep areas are displayed in hot colors, red and orange, while flat areas are displayed in cold colors, green and blue. I usually say the classic one, consider the blue as the sea, the green as a valley, and then the rest like a hill. The red segments are displayed in steep areas, while the blue segments are displayed in flat areas. The cross point of this segmentation represents the apex of the cornea. Besides the shape of the map, parameters should be studied particularly on the steep axis at the 5 millimeters central circle. The normal pattern is the symmetric bow tie, as we considered. Again, on the anterior sagittal map, we need to consider like two segments, the A and B. They are equal in size and their axis is aligned. The two opposing parts, the superior and inferior on the 5 millimeter central circle, these are the points that we need to consider. Normally, the inferior point has a higher value than the superior one. The inferior to superior difference should be less than 1.5. The superior point may rarely have a higher than the inferior point, and in this case, the superior to inferior difference should be less than 2.5. The symmetric bow tie pattern represents the regular astigmatism, which can be with the rule, against the rule, or oblique according to the orientation of the symmetric bow tie. In with the rule astigmatism, the symmetric bow tie is within 15 degrees of the vertical meridian of the cornea. Against the rule astigmatism, the symmetric bow tie is on or within 15 degrees of the horizontal meridian of the cornea. And in oblique astigmatism, the symmetric bow tie is neither vertical nor horizontal. The superior bow tie pattern can be encountered in kmeratoconus when the K readings are abnormally high. Now, these are some patterns that help us identify irregular maps that we see. So if we identify these patterns, when we see Pentacam, in order to interpret it, it's easier for the eye, once you are familiar, that you see these patterns. They are divided in 4 different groups. I'm going to break down each one of them, but as just a general rule, we have the group A, which are eyes in this group are considered normal when the maximum, the Kmax is less than 47.2 diopters. And there is moderate risk when the Kmax is 47.2 to 50 diopters, and then high risk when the Kmax is greater than 50 diopters. Then we got the second group, the group B, the difference between the 2 opposing points of the vertical meridian in the second circle of numbers, so almost the 4 millimeter central zone, must be examined. So we got the superior steep and the asymmetric bow tie superior steep patterns are considered moderate risk when the superior to inferior difference is 2.5 or greater, and then the inferior steep and the asymmetric bow tie here on the right and asymmetric bow tie inferior steep patterns are considered moderate risk when the inferior to superior difference is 1.5 or greater. I know it sounds too technical. We're going to show some examples a little bit later on to make this a little bit more familiar. I'm afraid this is the theory behind everything. And for eyes in the group C, the angulation between the axes of the 2 inferior and superior segments of the bow tie is measured, and these 2 patterns are considered high risk if the angle is greater than 22 degrees. Otherwise, they're normal. Finally, in the group D, its pattern should be considered as high risk, regardless any parameter. I'm going to break them down a little bit now to make things a little bit easier. I know this slide was very busy, but familiarizing with this simple slide will make the interpretation of the Pentacam much easier. Considering the first group, regarding the abnormal patterns, we have the round pattern, the oval pattern, and then the symmetric bow tie. In the second group, we have the superior steep, the asymmetric bow tie superior steep. The superior to inferior difference is more than 2.5. The inferior steep, and then the asymmetric bow tie inferior steep. The difference from inferior to superior is more than 1.5. That's suspicious. Finally, other abnormal patterns, we have the symmetric bow tie with skewed radial axis. The angle between the axes of the 2 lobes is more than 22 degrees, and the asymmetric bow tie with skewed radial axis, the angle between the axes of the 2 lobes is more than 22 degrees. Finally, all these abnormal patterns are considered suspicious when we have the butterfly pattern where the bow tie is horizontally aligned with the lobes inferiorly angulated or like a wing. We have the claw pattern, also known as the kissing birds. The wings are joined inferiorly with a central flat area, typical on pellucid marginal degeneration. Then we got the vertical Ds or junctional circular shape where the 2 lobes are laterally connected. Then we got irregular vortex pattern, and finally the clown smiley face pattern. Another map that is not used very frequently is instead of the sagittal map, is the anterior tangential map. And this map helps describing the corneal irregularities. The tangential map is better for evaluating the corneal periphery and is more capable of locating the cone in kmeratoconus. Now, in another part of the Pentacam, which I'm going to show you some examples, we have the elevation maps. The elevation maps are very important. It describes if there is any irregularity of the interior or the posterior surface. They describe the height details of the measured corneal surface by matching it with a reference surface. The points above the reference point are considered elevations and are expressed in plus values, and those below the reference surface are considered depressions and expressed in minus values. This is an example of the elevation map. You see the minus values and the plus values over here. These reference bodies, as we described, I'm going to only mention them because it's too technical sometimes. We have the toric ellipsoid body, the spherical body, and the float mode. So how do we interpret these elevation maps? We look at the values within the central 5 mm circle. Elevation values on the front surface should not exceed the 12 microns. Elevation values on the posterior surface, the posterior surface is the lower map, should not exceed more than 15. So if you see anything more than 12 or 15, remember that as a number, consider it suspicious. Then if we have an isolated island, which I'm going to explain in a few seconds, on either the front or the back surfaces, it should be suspected even when the values are within the normal limits. For example, on a classic elevation map, the normal shape of the cornea with regular astigmatism is a symmetric hourglass. Some examples of abnormal elevation maps, shapes, because it's all about having what is a regular shape and then recognizing what is the abnormal. For example, we might have the skewed hourglass, or we might have like a tongue-like extension, or we might have isolated islands. This is the normalish shape of the hourglass. And then we got abnormal isolated islands, if you see here, these two patterns. And then we have abnormal shapes that they have like tongue-like extensions or isolated islands over here. Again, skewed hourglass. And finally, the last map on our 4-map refractive map is the corneal thickness map. It has 3 main landmarks. It has the corneal apex, the thinnest location, and the 2 opposing points in the vertical meridian at the central 5 mm circle. The normal difference between the superior and inferior point is around 30 microns. So if you have a look at the pachymetry map and you see anything different, it is suspicious. Now, again, on the corneal thickness map, some abnormal shapes to consider. We might have a horizontal displacement of the thinnest location. If you see this map, for example, the thinnest location is over here. So there's a horizontal displacement, or we might have a vertical displacement of the thinnest location. And again, we might have a bell-shaped pattern, like here. If you see this one pattern over here, this is classic of the pellucid marginal degeneration, or keratoglobus when we have generalized thinning that reaches the limbus. Now I'm going to discuss about another pattern, another map of the Pentacam, which is very important to interpret, especially in abnormal ectatic corneas. It's a Bellin-Ambrosio enhanced ectasia display, BAD. We have some parameters to take into consideration, and some of these are the corneal thickness spatial profile, which describes the average progression of thickness from the thinnest point to the corneal periphery in relation to zones concentric within the thinnest point. And if the red curve deviates at the 6 mm circle or after, that's normal. The S shape is usually seen in ectatic corneal disorders. And after that, we have the percentage thickness increase, with a percentage of progression of the same. If the red curve deviates at the 6 mm circle or after, it is normal. Upwards deviation of the red curve in pellucid marginal degeneration, and flat red curve in Fuchs corneal dystrophy. We have another parameter, the arcmax, the Ambrosio relational thickness, which represents the ratios of thinnest point pachymetry and the pachymetry progression index. And finally, we have the deviation index, which describes the final overall map reading. So I'm going to go a little bit on some practical examples. Here we got a 17-year-old patient referred into clinic for possible keratoconus. We have the parameters here. We check the quality, the Q value, we see the astigmatism, the flat case, the steep case, the total topographic astigmatism. We check the Kmax, you see it's more than 50, so that is somewhat suspicious. And we start seeing the first map, the axial sagittal curvature map. You see already that it's not regular. It has this inferior steepness over here with this difference between superior and inferior part of the topography. Then we got the front elevation map. Instead of having the hourglass, we have these two islands, and you see there is an elevation of around 14 microns. Then continuing down, the back elevation, again, we have two different islands with elevation of 32 microns. And here on the corneal thickness map, we see that there is a displacement of the thinnest location. So already you see that there is a non-normal topography. It's possibly that it's related to kmeratoconus. And this is when we have the Belin-Ambrosio display, where this is a map that we take into consideration and to see various parameters, which I'm going to try to explain. For example, we have on the left part of the map, we have the front elevation and the back elevation, and we have different maps. We have this map and evaluates the anterior front and posterior back elevations within the central 8 millimeter zone. It displays a comparison to the traditional best fit sphere, a comparison to the enhanced reference surface, and then the difference between the two. And this is a very good. This is a very good map because the difference between the comparisons, again, the traditional best fit sphere and the enhanced reference surface, is likely to be minimally normal corneas, but they expect to closely. But in abnormal corneas, they manifest small changes in elevation. So by looking at these maps or the difference of these maps, it enhances any problems in elevation in the anterior map or the posterior map. Then we got this the corneal thickness spatial profile and the percentage thickness increase as we described earlier. And this one, there is a slight change if you see before the 6 millimeter point. So that is not considered something normal. And another thing to take into consideration are this deviation, standard deviation numbers, scores that we have. This is the front deviation, the deviation from the front. This is the deviation of the back, and this is the deviation for pachymetric progression, and this is the DA is for relational thickness, and the DT is the deviation from the thinnest point. All these give you a final score, and 0 is considered to be normal, but any value over 1.65 is considered suspicious. Any value of the D score more than 2.69 is considered abnormal. So if you take into consideration, you see a map like this, and you start seeing that there is elevation in the back. In this particular one, it shows that there is elevation in the back, and taking into consideration these parameters and the final D value, you see that this cornea is not normal. The other eye of the same patient, you see that there is on the corneal sagittal curvature map, there is some irregularity, but it's still considered within normal. The elevation front map, it has a small elevation +5, which is supposed to be within normality, but you don't have the classic hourglass. You have two different islands. The elevation in the back, though, is a little bit over the 15 microns that we mentioned earlier. And there is the thinnest location of the corneal thickness is a little bit moved inferiorly. The Belin-Ambrosio enhanced display, in this case, as we saw earlier that there was a slight elevation in the back, shows that this cornea is considered to be suspicious because the d-value is less than 2.69, which is supposed to be abnormal, but it's more than 1.5, which is 1.65, which is considered to be closer to standard. So this is the right eye has keratoconus. Instead, the left eye is suspicious of subclinical keratoconus. Then have another patient over here. This is, we look at the Q values again, the astigmatism, which is around 3.5 diopters. The K max over here is more than 50 again, so it goes in the suspicious area. If you see the axial sets, the curvature map, we have the asymmetric bow tie inferior steep. There's a big difference between the superior and inferior case. On the front elevation map, again, two different islands with elevation more than 17. Posterior elevation plus 39, two different islands again here. And we have a thin cornea with a deviation of the thinnest point. So it's an irregular cornea. There is posterior ectasia. And moving on to the Bellin-Ambrosio display, we see the elevation back, and there is also elevation in the front. We see here in the corneal thickness spatial profile that there is a change before the 6 millimeter spatial diameter pattern we see. And by looking at the maps, the deviation standards that we have, the d-value is 4.92, that shows it's an abnormal cornea. It's the same patient, but the left eye, you can see that despite having astigmatism of 2.8, you can see the case that they are very steep. You can see the difference between the superior and inferior. There is a big frontal elevation and also elevation in the back. And the thinnest point on the corneal thickness is 411 microns. And this is a classic case of a keratoconus. Also, if you notice the corneal thickness spatial profile and the percentage thickness increase, they have this S pattern, which is very typical, and the d-value, as you see, is 24.27, so it's a very ectatic cornea. Now, I'm going to show you another case of a 17-year-old child, yes, that was referred in the clinic with suspicious corneas by his optician. You see the total astigmatism is around 2.2 diopters. The K max is 47, so within normality. So we see the symmetric bow tie pattern. There's not any big difference between anterior and superior. We have hourglass elevation, but there's not any actual elevation on the cornea on the elevation map. The same, though, the elevation back, there is this difference like two islands, so that's a little bit suspicious. And the cornea seem to be the corneal thickness map seem to be normal. On the Bellin-Ambrosio enhanced display, we don't see any difference between the elevation front, elevation back maps that we have here. And the d-value you see is 0.45, which is considered to be normal. The left eye, again, symmetric bow tie, Kmax 47.3. Elevation map seems to be, has the normal pattern of symmetric hourglass. The elevation back, though, has this two different islands that I mentioned earlier, but not any actual elevation in the elevation map. And corneal thickness map is normal. I'm going a little bit to details, so how to start to interpret these maps that we see. Taking into consideration then the Bellin-Ambrosio display map, this, we don't see any elevation in the front, we don't see elevation in the back. The normal corneal parameters, the corneal thickness, spatial profile is normal, d-value is normal, the score is normal, so it's supposed to be a normal cornea. Now we have a 17-year-old child referred by the optician for suspicious keratoconus. The astigmatism was around 4.3. Q value is this one. Kmax around 49.4. Now we got the asymmetric bow tie inferior steep. There's a big difference in the superior and inferior cornea, sorry. On the elevation map, we have two different islands, not any actual elevation, the same in the posterior elevation map. In the corneal thickness map, there is the thinnest point seems to be on the center. On the Bellin-Ambrosio map, we see that there is some suspicious posterior elevation, and the final D-score is 2.52, so it shows that it's abnormal. So it's a patient that we consider that has subclinical keratoconus. We monitored this patient a year after to see if there was any progression or any change, and that was his Pentacam in 2018, and that was his Pentacam on 2019. There was not a big change, and what we try to monitor in this case, if there's any progression of keratoconus, is to consider the patient to have a corneal cross-linking, that we know that it stops the progression of keratoconus, and that's a very good tool that we have in our disposal. Now, what happened is that this patient was supposed to be seen 6 months after, but COVID happened. We don't know why the patient did not have an appointment, so he ended up coming a year and a half after. This is the Pentacam that the patient had in November, and this is the first Pentacam that they have in the first map on the left back in 2018. You can see that there is a big difference just observing the two maps, and I'm gonna show you the difference again on the left eye, how it was. That was the map in 2018 on the left, and the map in 2018 on the right. Again, not a big difference, so it was considered stable, and we decided to continue to monitor him for another 6 months. Again, when the patient came back, this is the map on the left eye. You can see, so it's not very clear, I'm afraid, but this one is 2018. You see the axial sagittal curvature map, and you see the difference. We had 46.9 and 53.2, and then a few years, 3 years down the line, but a year and a half that actually the patient had missed the appointment, went from 48 and 56.5. So we had this progression of his keratoconus that happened within a year and a half. This is the Bellin-Ambrosio map display of the right eye when he had the last Pentacam back in November. You can see the parameters, it's 4.66. If I go back a little bit, you see the right eye was 2.52. This was the suspicious eye. So we ended up with a 4.66, and that happened only in a year and a half. So it's very important to advise and counsel your patients that if they have keratoconus and it is considered to be stable, and they are in this sensitive age of their 16, 25s, 30s, to follow the appointments and chase the appointments as well, because we know the hospital system is not perfect. So if somebody doesn't get the appointment, they need to understand that they need to chase the appointment. This patient did not chase the appointment, despite knowing what is the consequences. And I'm afraid that they ended up having this progression of the keratoconus. And if you see the left eye has the major progression. The good part of this story, at least, is that there was not, despite having this big progression of his keratoconus, his visual acuity actually with his glasses was very good, and we sent him for corneal cross-linking to our colleagues in QVH, who are very good for helping us in that matter. Now, I'm going to discuss about some clinical applications in everyday practice of Pentacam, despite the keratoconic patients that I just mentioned some examples. And also for your point of view, Pentacam is very useful, at least in a department, and our colleagues that put and fit contact lenses, and it's very helpful to them. I'm going to discuss about a couple of cases, make it a little bit more practical. We got a female of 82 years old patient who had cataract surgery in the left eye and was listed for cataract surgery in the right eye. She had a pre-assessment, and she was found that she had 9 diopters of astigmatism in the right eye, and the surgery was cancelled because she happened to be on a list of another surgeon, and they noticed that they had 9 diopters of astigmatism, and they thought something's wrong. Then she was sent to be reviewed in clinic by me, and she was found to have Saltzman nodular degeneration. The hostile refraction was done, and she was a +8 -5 astigmatism, and the left eye following the cataract surgery was +1 -2. Then on decision, when I saw her, we decided to schedule to have superficial keratectomy, which is practically smoothing the surface of the cornea and removing these nodules. Saltzman nodular degeneration these are a couple of photographs that I found on the web, they're not mine, is slowly progressive condition with gray, white to bluish nodules measuring 1 to 3 millimeters each are seen anterior to the Bowman's layer of the cornea. They're usually bilateral, and this can be located near the limbus or the mid-peripheral cornea. There's not any specific etiology described, but many cases appear to be idiopathic with no history of actual keratitis. It can also occur in patients with chronically dry eyes, blepharitis, trichiasis, previous ocular trauma, and post-operatively. So in this case, we did superficial keratectomy, which is scraping the surface of the cornea, placing a bandage contact lens, and let the cornea to heal in order to have and do a proper good biometry. Ideally, some colleagues of ours have available PTK. They do this with laser, which is much more accurate, I have to say. I'll show you an example. This is the biometry. Biometry is what we use from IOL Master. It's the tool that we use to choose our intraocular lenses. And this is the biometry when the patient was seen by my colleague. This is the right eye. If you see, she had a very small axial length. That's why the refraction was a +8, if you remember. But look at the case. They are very, very, very steep case. And the power recommended on the SRKT formula was a 28 lens. But considering this case, I would not consider to use this biometry. This patient had superficial keratectomy. This is her Pentacam after the keratectomy. I'm afraid I don't have it, the one before. I was not saved. I don't know why. You see, she has this after the keratectomy. She has a much more smoother corneal surface. There is symmetric astigmatism. There is elevation. There's not an actual elevation front. The elevation in the back, I have to say, considering that she had superficial keratectomy, and if you see the corneal thickness map here, it's a little bit all over the place. So it can be considered to be much reliable regarding the corneal thickness map because it has lots of scarring. So these maps are to be interpreted. It's mainly to have an idea following the superficial keratectomy, how was the axial and sagittal curvature, and actually get some case. And this is another tool that we use for our cataract surgery. This is a cataract pre-op. It evaluates and gives you an evaluation of the anterior and the total corneal refractive power, and it gives you a comparison between the anterior and the total refractive power and the difference between the anterior and posterior astigmatism. This is taken into consideration not for this case, but generally for toric lenses or for multifocal lenses. This is another tool that we have. It's the power distribution map. That we see in various concentric rings around the cornea. The one that we take into consideration is the 3 or the 4 millimeter K power to consider in some cases when we have irregular corneas. So following superficial keratectomy, the case that we have, before her surgery were like 38.01 and 47.1. with the same axial length. So following superficial keratectomy, the case that I got was 42.65 and 46.89. She had this astigmatism. The lens that I chose was a 25.5. If you remember, the lens suggested before the superficial keratectomy was 28. And the final visual outcome was plus 0.5, minus 2 at 70 degrees. The patient's visual acuity corrected was 6.9. So the patient was happy, and likely the surgeon who saw her last time did not proceed with surgery and forward her to us to have a better look at her corneal surface, and then eventually proceed with what we did. Another case, we have a patient, 73-year-old patient, previous radial keratotomy surgery. This is a surgery that they did many years ago to correct refractive errors. I think it was invented or done in Russia many years ago. There are still a few patients that they do come in the clinic and they have it. This is something that now we consider very barbaric thing to do on the cornea. She had recent cataract surgery, successful cataract surgery in the right eye by a colleague of mine, with very good refractive outcome. Her vision was 6.9 in the right eye, and she was listed to have the left eye done by me. So I had to match my colleague's achievement, and that was very difficult. This is the pentacam from the patient. As you see, the cases are very, very flat. And have a look here at the corner, the axial, the sagittal curvature map. As we described earlier, this is the C, so it's a very flat cornea, and this is the valley, so you got a very, very flat cornea. On the elevation map, you can see that it's totally abnormal. You don't have any hourglass or different islands, and don't take into consideration these elevation maps because these are not reliable measurements due to the thickness and the scarring of the cornea. Again, thickness of the cornea is a little bit irregular. There's not any symmetric. There are not many symmetric areas of your cornea, of the patient's cornea as well. Taking into consideration, in these cases, I always do a cataract pre-op map just to have an idea of any posterior astigmatism, in case we want to do, or to understand if there's any other problem with the posterior cornea. In this case, the total astigmatism, the anterior with the total astigmatism was more or less the same. There was not any big difference. This is a map again from the power distribution map. We use, in these cases, we have previous RK surgery. We do some calculations through this, using this tool, which is on the website, the ACRS IOL post-refractive calculations. So this is online. We use these parameters in order to calculate the correct IOL for patients who have previous RK. And on the Pentacam, one of these parameters is on the power distribution map that I was describing earlier, where we have to put one value that is there. This is very useful in order to make a proper calculation for this patient and do something reliable, because RK patients are very unpredictable. And the problem with RK patients is that you do the surgery and the cornea and the changes of the cornea can take up to 3 months. So you're not sure about the actual manifest refraction. You have to wait at least 3 months sometimes in order to make sure or be sure what is the actual final refraction. And also there are some technical problems regarding the surgery that had a couple of colleagues that it hasn't happened to me, that the cornea actually split and they had to suture it following the cataract surgery. Luckily, I managed to match my colleague's achievement. The final refraction was plus 0.5, minus 2, and visual acuity was very good. Now we have another patient, female patient, 70-year-old, very high myopic with high astigmatism. She was listed for right eye cataract surgery. This is her biometry. You can see the axial length on the left. It's 26, so it's a long eye, but she had very steep case, and that was on the day of the surgery, so I thought there's something wrong, because I'm afraid most of the times we do the surgeries without seeing the patients before, so we only see them in theater. They are already listed by other colleagues of ours, and we find these patients in our theater list. So you can imagine our surprise sometimes when we see something that is not regular and it hasn't been correctly investigated. So I requested to have a Pentacam on this patient. So if you see here, very steep case with a Kmax of 55, you see this hourglass, skewed hourglass pattern, anterior elevation on the posterior map, posterior elevation, and there's a deviation on the thinnest point. On the Bellin Ambrosio display, you see like the posterior elevation and anterior elevation. We have the D value of 9, so it treats of a patient of keratoconus. The patient was not aware. 70-year-old patient was never aware. She had the glasses, she had good vision. Nobody actually told her that she had keratoconus, so there was not. She did not mention anything like that on the pre-assessment because she was not aware rightly. Again, this is the cataract pre-op map that I always use to see if there's any irregularity of the posterior surface as well. And in this case, as I mentioned, it was a very myopic patient, and we discussed a lot about the possible refractive outcome. And she was a -10, but she expressed the will also to be able to read without glasses and have the glasses for everything else. So after making some calculations using the power distribution map, because we have usually in keratoconic patients, we have some guidelines from our college, and when the average case are less than 55, we use the current biometry that we have, but we have to aim for a -1, -0.5, because there's a big deviation, hyperopic deviation when doing the surgeries. But this patient expressed also the fact that she would like eventually to be able to read without glasses. So by using this power distribution map and extrapolating some case in the 4mm zone, I adapted this into the IOL master calculations. And after discussing with her, I did tell her that she might end up with a refractive surprise, or she might end up with a metropia. So I decided to go with a +8.5 lens on the right eye, and she ended up with a -2.25. So the vision was 6:15, and I was not happy personally, but the patient was satisfied. She had much clearer vision. It was a dense cataract, and now she wants to have the other eye done soon due to anisometropia. The problem was now, if you see this biometry map here, I use this method of calculation, and I had a refractive surprise. It was much more short-sighted than predicted, but I had to match the other eye. And this is the biometry that I used in the left eye with a target refraction of a -3. The right eye ended up -2.5. So by using the same calculations that I used in the left eye, using again, these are the parameters at the Pentacam on the left eye. There was anterior elevation, posterior elevation, and thinning. Again, indication of keratoconus on the Bellin Ambrosio display. Using the same calculations that I did on the right eye, she ended up with a -3 refraction and -1.75 cylinder, with a visual acuity of 6 to 7.5. So very close to the right eye, which ended up -2.5. This is just to show you how unpredictable things can be. The patient was very happy, and it all counts on the counseling of the patient. We had a long discussion about the refractive outcome and the possible refractive surprise. I have to say that the patient trusted and had faith on what we do. I was very happy with the final visual outcome. I was not very happy after the first eye, because as surgeons, we want to be as accurate as possible and give the best to our patients. But at least we managed to achieve the desire to for the patient to be able to have some reading distance, good vision. And finally, we have another case of 76-year-old patient who had previous LASIK surgery with a posterior subcapsular cataract and pseudoexfoliation. He was listed for eye cataract surgery. If you see his Pentacam, you can see that he has a nice case with a very good postoperative astigmatism. The cornea, the Kmax is normal. You can see nice case. You see this irregular pattern on the elevation map, and the back elevation. There's not any abnormality, and the thin cornea, or the thinnest location of the cornea, which has normal thickness, corneal thickness. We do the pre-cataract op map to check if there's any irregularity of the total and the posterior cornea, and any possible change. This is a very important map in case somebody wants to consider a toric lens or eventually multifocal lens, checking these parameters. We check again the power distribution map, and we use the TrueNet power calculation when we enter these parameters into the online calculator. If we did not take into consideration the fact that this patient had previous refractive surgery, by using the normal calculator for his intraocular lens, it would be we would choose normally like a +20 lens. If we didn't know about this patient's previous history. But since we know the patient's previous history, we do all these investigations, we do Pentacam, and then we use modified formula, which is called the Haigis L, which is a formula that has been developed for after many thousands of surgeries with some constants that they have been developed, and they're very, very accurate. So we choose the ablation on if there's myopic or hyperopic, and we use the appropriate formula. And plus, for reference, we use again this tool, the online calculator, that we put these parameters, and also if you have the parameters from a topography or a different kind of topography, and then you get an outcome from a lens point of view, and you get the final refraction of the patient, which was a -0.5 with -0.5 cylinder, and his VA was 6.6. Just to let you know exactly, if we didn't take consideration that the patient had previous refractive surgery, the lens that we would use would be a +20, and the lens that we used was a 21.5, and still ended up a little bit short-sighted, but the patient was very happy. And finally, just to close, this is a nice OCT for a patient I saw recently. He had a nice, he was walking around the bushes or something went into his eye, and he had a thorn on his eye. Well, just recent, I just wanted to show you this. And that's it. I finished. I hope it was a little bit interesting to you. I hope that I didn't use too much theory, and I tried to stick on most practical stuff.
Thank you very much, Mr. Ioannidis. That was really interesting. That was. We do have some questions. First question is, so how repeatable are the results on Pentacam?
Well, that's why you have to consider the quality. And sometimes when I see some of the parameters are in yellow, when you do the Pentacam, you see it has some quality parameters. So if you check these parameters are normal or considered to be normal, it's good. Repeatability, it depends on many things. I go with the advice of what the company representative told us, to do the Pentacam in the same conditions. Don't use any lubricating drops before the Pentacam, or 10 minutes, 15 minutes before, because that can change the parameters and the values that we see. Do it in a dark room, completely dark room. So if you keep the parameters of the exam itself, it's supposed to have good repeatability. If you start changing things or doing some patients dilated, not dilated, or some patients that use some drops before, or not in dark conditions, then the repeatability is not good. So I actually go with the advice of the representatives who have more experience than us from that point of view. I don't know if this answers the question.
It does, yeah, definitely. And the question: if we get a patient referred in for cataract surgery and we do a Pentacam, but they've previously had laser surgery, what information do you require? Do you need their previous refraction? Or...
Ideally, you want the previous refraction, ideally, but you would like the previous case. If the patient had this information, that would be very good. Not only because it will give you something more reliable. At the end of the day, you want the best possible refractive outcome as a surgeon, or generally, whatever. This is our job. So we need to be, and we try to be as accurate as possible. Ideally, you would like to have all the parameters. And then you also use the tools that we have nowadays. For example, we're very lucky to have the IOL Master 700, which has also the TKs, which is another part of software that considers also the posterior astigmatism, and it gives you the best possible outcome. If we have the previous case as well, we can use them in the other tool that we have, the online web tool calculator. So I use both, and then I try to pick the average, considering with a small experience that I have so far, I have good outcomes. So the more information you have, the more data you have, the more accurate you are going to be with your results. Another thing is, bear in mind that most of the patients that I've encountered, most of them, you ask them, were you short-sighted or you long-sighted, myopic or hypermetropic? Some of these don't even remember. Yeah. And you might get the surprise. I had a couple of times that when you see the Pentacam, you can tell if a patient had a myopic or hyperopic ablation. And you're gonna be surprised that some people don't remember. One thing, if they have any previous refraction, that would be helpful. But if they don't have, you have to check your Pentacam parameters, because there are some things in some ways in order to figure out if the patient had previous myopic or hyperopic LASIK. And that's very important, because if you don't have the previous information and you want to choose your IOL Master formula, you have to put if the patient had myopic or hypermetropic ablation, and you need to know these details, otherwise you're going to be too far off.
Thank you, that's lovely. Is it possible to have keratoconus affecting the posterior surface only?
Yes. If it affects the posterior surface and the vision is good, it's subclinical.
Yeah. Would that
so
change?
It is still keratoconus. It is still an ectasia, but it's not a manifest ectasia. So it can be a manifest ectasia only posteriorly. Yes. Perfect. That's why usually they say that it's more sensitive. Keratoconus is more sensitive in the posterior as well, astigmatism.
Yeah. And I've got a question from a colleague. I find retinoscopy picks up early keratoconus. Would the Pentacam pick this up earlier?
Earlier, yes. The Pentacam is Pentacam Topography. It's supposed to give you also this information of any posterior elevation that you might not be able to check on retinoscopy. In retinoscopy, you get this oil droplet, not the scissor reflex. I think it's an oil droplet reflex that you have to, but you are more experienced than me from that point of view, Ian, that you might get. But on the suspicion, I think the Pentacam will give you this confirmation. I have patients, the youngest patients that I saw was like an 11-year-old patient. And on the previous example, there was a patient who was referred, who was 10 years old with 2.5 astigmatism, something like that. But it was nice and regular, so they didn't have any problems. We monitored the patient as well. And now the patient's like 13, 14, there was not any change.
Yeah, perfect.
So I have also faith in my tools and the machines that I use, my toys. So the more you use them, the more you trust them, the more you gain an experience. And that's the only recommendation I have. Whatever you have, we have the Pentacam because it's considered to be gold standard, but there are many, many nicer tools as well that we can use for topography. But the more you learn about it, the more you trust your machines, the more you can possibly offer to your patients and be accurate.
And you trust your colleagues using the machines as well?
Always.
Good answer.
And then sometimes I tell them to repeat it.
How important is the quality of the tear film on the readings?
It is. That's why I mentioned earlier, and that was a tip from the representatives of the Pentacam, that to try to, in order to have consistent readings, is not to put a lubricating drop before the Pentacam. But I repeat, but if you have a patient that eventually has a problem with dry eyes, you're not going to get a repeatable or consistent measurement. So you have to repeat the measurement with a patient who has dry eye, and then also repeat the measurement by using some lubricating drops before, to try to improve the corneal surface and have a more reliable and accurate measurement. So in some cases, you have to repeat the measurements. If you have a dry corneal surface, you also examine the patient. It's not only that you do a Pentacam and you send them away, you see them on the slit lamp, and then you start to wonder, this is not a normal surface. I need to improve the corneal surface before doing a Pentacam to have something accurate. Yeah.
Lovely, thank you. Do we offer cross-linking treatment for subclinical keratoconus?
I'm afraid in the NHS we need to show proof of progression before doing cross-linking. Again, my view is that if we have a patient with subclinical keratoconus, we need to monitor, and any change, any progression, even subclinical progression, is a sign of progression. I don't know if it makes sense. And they should be offered cross-linking, because I think cross-linking is more than 20, it's also older than me, more than 20 plus years. And I think it's doing grafts at this era for keratoconus. I think that's something that should not be done, having in our disposition the cross-linking. We have it for decades. So why we're still doing grafts?
Yeah. Do you treat
that many grafts, let's say?
Do you treat keratoconus yourself, or do you refer to?
I'm afraid I refer to my very kind, good patients in Queen Victoria Hospital, and also in Brighton, who have very good corneal colleagues, very experienced and very helpful in these cases, because when we refer them, they're right on, spot on, and they treat them, even though I'm trying to get cross-linking here locally.
Brilliant.
At least that.
That's all the questions we have. So thank you very much for tonight, Mr. Ioannidis.
You're welcome. You're welcome. I hope I went a little bit fast, some details, but that's the nature of this thing. I'm afraid it's getting hands-on experience and being exposed to that, seeing many scans and getting your eye used to the various deviations. That's why the patterns are very useful, because you see something normal, but when something is abnormal, it takes your interest, and then you start to dig into it.
Mm-hmm. That's a very interesting but very in-depth subject, isn't it? So a lot of information there. But
trying to squeeze it in 1 hour, it's a little bit difficult.
So thank you everybody for watching for tonight. I will try and get the CPD certificates out this weekend, and the webinar video I will put up on the YouTube channel probably early next week. The next webinar I am in the process of arranging. So please keep a watch on the WhatsApp link, and I will update you once that's sorted and finalised. But thank you all very much for your time tonight. And once again, thank you very much, Mr. Ioannidis, for your time as well.
Have a good night, all.
Hope to see you all soon. So thank you very much indeed for joining us tonight. Take care.